Let me pull that up. So just to kind of give you a bit of background, I think we've covered this in PACES meetings, but if you have missed those, one of the deliverables for the EMSC grant, this grant cycle, which we just started a new 5-year grant cycle on the 1st of April. One of the larger deliverables within the grant is to stand up a pediatric-specific recognition program for the EMS services, for the EMS agencies in Arizona. And so Jordana has done a tremendous amount of work looking over the other states. I want to say there's, and you'll have to back me up on this, Jordana, if I'm wrong. I want to say there's something like 10 or 11 or 12 other states that have EMS recognition programs for EMS services specifically. Arizona is recognized thanks to the efforts of Ann Stafford and the Arizona AAP. We are notable in amongst the EMSC grant program for having a good hospital recognition program, and so this is going to be hopefully tying. I got you, Chief Pro.
Oh, sorry.
No worries. This is going to be separate for now, as far as we can see, but to help sort of cap that together in terms of a hospital recognition program and then also an EMS recognition program. And that's some of the input we're going to ask you for in terms of how to move forward with sort of the oversight of this. But for now, let me share my screen and I will let Jordana tell me when to move the slide over. So if you'd like to review the long form, what we're calling the long form, again, and I'll drop it in the chat, in fact, just so we have it.
And the long form is a hard, very rough draft, so don't think it's final in any way.
Right. Did you want me to leave it like this, Jordana, or did you want me to go full screen? Did you want the notes at the bottom, or can everybody see that, or do I need to adjust anything?
You can do it full, and I have the notes here on my side.
Okay. So for those of you that don't know, Jordana has been a member of PACES as our Family Advisory Network representative. And this grant cycle, one of the other grant deliverables was a further emphasis on Family Advisory Network member involvement in the grant. And so we have added her to the grant in the form of a contractor. And so we're very happy to have her in a more integrated fashion. And that's how we get some of this fantastic work. And so Jordana, go ahead if you'd like to.
Okay. So like Adam said, this is going to be our Arizona EMS Pediatric Readiness Recognition Program. This is a voluntary program that will in no way impact your agency's licensure by the Arizona Department of Health Services or our Office of EMS and Trauma Services. This will be a 3-tier level program that recognizes EMS agencies who have demonstrated a commitment to excellence in pediatric emergency care and better healthcare outcomes for pediatric patients. Many other states have already put this forward, and so we are just looking to see if we can put forward our own program, like Adam had said. I have taken from different states and kind of built our own. So Adam, go ahead.
Sure. Oops, thank you.
So this is kind of our overview of what we're doing. Our goal is we would like to officially have it up and running by next year's EMS, which is in May. We would like to be fully up and running. This gives us an opportunity to promote the program throughout the state and EMS services in Arizona. This recognition program started, like Adam said, this cycle for the NOFO grant, which was April 1st. So we put all this together from then till now. We would like to establish a steering committee for this program as well, to be able to have a committee that can help oversee this program and help us with our involvement with the agencies. One of our biggest obstacles for this program is our PEC involvement, but as a side project, we are doing a PEC recruitment for both EMS and hospitals that's taking place, and we're trying to work together to overcome that obstacle. Go ahead, Adam. So this is to help ensure that every child in Arizona receives the best pediatric care in the event of severe injury or illness. Also to advocate for the unique needs of children of all ages. It ensures children in our state that have timely access to optimal medical care and to promote safety and injury prevention initiatives. Adam. So this, like I said, is going to be a 3-tier program. We're looking to possibly change the names of the levels to kind of mirror the hospital recognition program so that it's kind of more cohesive across the board. So these aren't set in stone. But each level will build upon each other. And the agency that has to meet the first level for level 3, they have to meet all those requirements before they can move on to level 2 and so on. Adam. Some of our critical criteria areas. So each of the levels in these tier systems has a criteria that is outlined in each level. And some of these criteria are, like I said, they have to build upon. So you have to meet all the criteria for level 3 before you can go on to level 2. Adam? So this is our first recognition level program. So this will be level 3. Some of the requirements that are required for this level is a designated PEC, which is a pediatric education care coordinator, specific medical equipment for pediatrics, which we have a checklist that is available, and it's in our long form, but it's through HRSA and the EIC. Participating in the national, state, and EMS surveys is a requirement. Patient and medication safety, safe transport policies in place for pediatrics, which most agencies should have already, but it's just a check mark. And CEs and educational skills and competencies will be required as well. So for level 2, all of that has to be met in level 3, but we also would like to require annual training requirements, partner with family and patient for family-centered care, policy and procedures for transport with caregiver in place. So it's a little addition to the other policy in level 3. And then the emergency preparedness protocols in place. And then for level 1, we would like to additionally add additional education outreach for child care providers, patient and family, and medical professionals. And QI initiatives will be a big one for this one. We have an outline here for the program. But keep in mind, it is kind of rough, but we'd like to achieve. So we were awarded the grant, as you can see, on April 1st. We want to do an outline of the program, which is our long form, the recruitment of work group, which was today, which is you guys and helping us do this. We want to get a steering committee put together and finalize our long form, our paperwork there. The next part of the timeline is a pilot agency. So an agency that will help us start this, go through the whole process, and then we can work out any kinks that are there before we launch it for all the agencies across the state. And then we would like to have an outreach for all the agencies across the state in January of next year and have them do all their site visits and get awarded their level by March. So that way we can have this outrolled in EMS week in May of 2024 so that we can have a little bit of a bragging right for EMS week to kind of promote it. Some of our next steps. We are currently putting together the work group, like I said. We would like to have the manual completed this fall. We like one or two agencies to help us with that pilot program. And then like, our biggest thing is to have this rolled out for EMS week. We think that'll be a great opportunity for us. So our goals for the work group sessions is to introduce this and give it kind of a background information, introduce the program levels and go through those and the process of the application program and then the form. So we'll break down the meetings to go through the long form, and this is kind of our outline for that. Adam, do you want to talk about the verses or do you want to stop there? You're on mute.
Nothing specific. I appreciate you putting that together to give just a really vast overview of what we've done so far, and really a lot of our are you done with the presentation? I'm sorry. Is there more?
Well, so the next part of it is for the hospital versus the EMS side, just to show the differences between the two programs. So I didn't know if you wanted to go further into it or if you wanted to stop there.
Oh, well, I think that's where we have to have a lot of discussion, especially with AZAAP about, like some of the terminology, like you had mentioned, about naming the 3 different levels, something similar or something that would be more parallel with the hospital recognition program. And that's sort of the input we're looking for about, I guess we're not certain how closely we want these programs to be, even though I know that sounds kind of silly, but like how close can they be without overlapping in a way that's not productive, I guess is, and so a little bit of feedback there about some of the differences. What should the main differences be from a hospital to an EMS program, and how closely we can or should mirror our EMS recognition. Our hospital recognition program from the AZAAP. And that's what I'll say about that right now, Jordana.
Okay, so then we can stop that for here then. If they have any questions, we can start doing that.
Sure. And so one of our questions, I guess, that to maybe motivate this is the oversight of this program. Where at least from my position, it's sort of hard to see. It's open-ended about how the program is going to be, I guess, managed, for lack of a better term. And that's the discussion we want to facilitate. Is that that our AZAAP partner uses a steering committee with particular members that are strategically chosen according to what's best for that application of that. And we would like to do the same thing. And and larger than that, one of our questions is we're going to have to perform site visits in a similar fashion that the hospital recognition program does. And so that's sort of where we're stuck with oversight and who is going to help us with perform site visits, and the composition of that committee itself. And so we were hoping to motivate some conversation about those topics.
Adam, this is Dale. Hopefully someone else wasn't going to speak. I hope I'm not interrupting anyone.
No, please.
I was perfect segue to some of the questions that I had. The hospital-based pediatric designation system started as a private-public partnership, but ultimately became a private venture, voluntary in that regard, and obviously would say more to this. But the Arizona Department of Health, Bureau of EMS and Trauma, we have statutory committees, we create guidelines and recommendations, and then we have our state regions for maybe EMS coordination, but there's not necessarily authority or oversight of the individual agency. So that's where I'm struggling is that, when it comes to administration and structuring of a pre-hospital pediatric designation system, are you proposing that this stay within the department and the Bureau of EMS and Trauma? Is it later to morph into a more of a private standalone governing body? For example, where we did the hospital-based pediatric emergency care, Arizona AAP essentially governs and administers that for us. What was your vision over time in that regard? That's kind of where I'm still a little bit.
Oh, that's my question. That's exactly my question. The only reference we have in the state is the AZAAP and their steering committee, comprised of the members that are best served for that function, for the hospital recognition. And so that's my question. And that's I don't have that vision. I suppose for the immediate and foreseeable future, it'll be housed at ADHS because it's an EMSC grant. This is a deliverable of the EMSC grant, and so it would make sense that at least for the time it would be sort of housed at the Bureau of EMS and Trauma at ADHS, with the EMSC me managing it. Going long term, I don't. Our question is, who is our steering? Do we call it a steering committee? Who's comprised of that steering committee, and how are we executing site visits? And so those are the pieces that we need. We're reaching out about to asking for help with. I see a couple of hands up. Julie or Ann, do you guys want to go first?
Yeah, I just wanted to add just something to what you just said. When the PPEC program originally started, the funding did come to ADHS through the EMSC grant funding, similar to this, and they still placed it with us, right, to facilitate it, but the funding was coming to, so it's kind of like they outsourced it, right, even though the funding was going to ADHS, so that's definitely an option.
Thanks for that background. Thank you. I honestly didn't know that.
And then eventually that funding ended,
Okay.
and the program became self-sustainable through the membership fees and certification fees.
But and bridge through the SPROC program too, though, right? So it took a little bit. Oh, I'm sorry. I'll speak later. I think
No, I didn't catch what you said.
I was just saying that it bridged through the SPROC program. I mean, it wasn't essentially an overnight event in which it could be self-sustainable and standalone. It was a lot of work.
Yes.
So I think if anything, I'm just adding caution to well thought out process and how this is going to, proceed and mature.
Yeah, a lot of the funding that ADHS was getting was going to maintaining the program until it became self-sustaining. So there was a lot of money invested by ADHS, even though we were facilitating it and the steering committee governs it. But it was still, it took 5-6 years, I think, before. Yeah.
Yeah,
and that's something we haven't talked about is costs associated. The conversation was brought up in one of the last PACES meetings about the costs associated with startup, whether they have to buy, particular equipment to meet these parameters. And so we haven't really talked about that. We haven't even talked about membership fees. We haven't gotten there yet. And so that's what we're hoping to gain from all of this. Sorry, there's a couple of hands up. Julia? Okay.
I just added my comment in the chat. I was just going to note, based on what Dale was saying, that we do have a couple existing voluntary recognition programs within the Bureau. One of them is for EMS agencies. If it ended up staying within the Bureau of EMS, we could potentially model it after the existing programs, and that one goes through EMS Council. And I'm also thinking that anything that we create here, especially if it stays in the Bureau, will probably have to get approved by EMS Council. But we could talk about that later, but just to note.
Thanks, Julie. Appreciate it. Debbie, I see you have your hand up.
Yeah, so another factor too, as I recall in the very early days when we developed the hospital program, we had champions, hospital champions that were really part of creating this what became kind of a collaborative, and then it moved over into that private sector in Ann's shop. What I'm wondering here is, do we need those EMS champions? Do they exist already? I mean, are there, transport providers who have maybe they're national and they have been certified in other states? I'm just curious how this, how this gets scaled up in the different industry.
Yeah, absolutely. Another one of the I guess pillars of executing this in a meaningful fashion is a parallel project that we have that's basically ongoing, which is what we call PEC recruitment, or Pediatric Emergency Care Coordinator recruitment, a lot of it rests with that person. Well, I mean, I'm correct me, Jordana, but I think all of the levels basically require somebody to be a PAC at that. Is that correct? At that
Yes.
EMS
Yes.
agency? Okay. So it's
We
sort
want
of
them to help promote the program and help with the program with the agencies to be able to help them with their education and their outreach programs and stuff like that. So we want them to be a like pillar in this program with it.
And so through them, we were hoping that they're gonna, I don't want to say carry, but that they're going to, I guess, do a lot of the work necessary to sort of enable this program to recognize agencies. Does that answer your question?
Yeah, I think what I was getting at is, we had a lot of rural hospitals that had very little experience with pediatric care. And so in order to get them on board, we have like Phoenix Children's and some of the other, larger systems that, did a lot of pediatric care that really helped sort of model this and kind of help push us out. And then we also then received, hospitals received a payment bump through Medicaid for participating in the program at one point. And that was those are a couple of ways that we were able to scale this up. And I'm just curious, what that looks like, with the EMS agencies. I just don't know if you guys had those conversations yet.
No, that's exactly what we're here for. And honestly, we haven't talked about scaling and in the management of that. And so my immediate thought is to lean on the experience of the AZAAP in terms of how they were able to expand and scale it and then support it at that size. And so I don't want to say that I'm heavily relying on that, but it appears to be the model that we would follow.
I will say, I think Dr. Woolridge has historical information that goes back further than my time here at AZAP. I will say that Medicaid bump, we were super excited about it and we thought it was going to make a huge difference. I think it made a small difference, but we did not see like the reaction from hospitals that we thought we would. And we continue to have hospitals, even while the Medicaid bump was going on, say we don't want to renew because of the cost. And we would explain that what you are making from the Medicaid bump more than covers, any cost associated with the program, but it just wasn't the motivator that we thought it was going to be. Dr. Woolridge, what are your thoughts on that?
Well, same, but to some degree, when it comes to hospital reimbursement, I think that was also the demise of the Medicare, because it was the hospital association that was the primary opponent who approached access, leading to that payment bump being removed after a period of time. Another comment that I was going to make, though, and this probably in response to Debbie's comment, or was said earlier, I think there really needs to be a buy-in from the medical directors. And EMS Council came up, and many of the more prominent EMS medical directors attend and or sit on the council. And I think in the structure of an EMS agency, essentially adopting a pediatric, I don't want to say prioritization, but a pediatric specific approach to their guidelines is going to need the medical director to essentially endorse that. So, and I don't know if these will necessarily get off the ground unless we have the medical directors behind this, which I think is going to entail maybe even a presentation to the EMS Council and maybe some sort of a feedback as to how responsive they would be. The other comment I wanted to make before I turn off my mic here is that you suggested a pilot scenario, and the comments suggested it would be a single agency. I would strongly encourage that there be a few pilot agencies, particularly one that fully represents a rural area, and then an urban area, and then maybe even a suburban area, because each of those agencies, based upon their resources and their service regions, are going to have very different struggles, and essentially a pediatric focused approach. So if you pilot, I would encourage you to consider different types of EMS agencies, because there's a lot of variation throughout the state.
Yeah, no, I totally agree. We had only talked about having a pilot agency, but yeah, we should definitely. That is a common problem in Arizona is ultra rural versus very urban, and so yeah, good catch on that for sure. Jordana, did you want to carry on? Did you have more slides behind this? I'm sorry if I already asked that.
It was just showing the different slides for the hospital versus the EMS side, like the
Okay.
pediatric liaison, just the wording and some of the stuff, the differences in the levels, just what they call it to what I had put on there, and then some questions about the steering committee was the next slide for their bylaws and stuff, and then it showed just this is what we were kind of looking at as to doing, and the last slide is what the hospital has as their, or the PPAC side has their members. What kind of members do we want on ours? And so to kind of reference between the two of them. The next one, next slide. The last slide.
Is this a list of who you were thinking are the representatives for our steering committee?
So yeah, I was thinking we needed somebody more from the fire department, from the EMS side, a rural, like how Dr. Wolder's saying, rural and non-rural or suburban.
Okay.
Have a family representative, have the EMSC director, have the PEC representative, the training officers for the departments, because they're heavily involved with how they train their staff for all the agencies. So I thought that was a great part. And then obviously the EMS manager.
Debbie, I see you have your hand raised.
Just for clarification, as I'm looking at this list, so is this, certification or recognition, whatever term is going to be used, is it for the transport agencies? Is it for fire departments who do the paramedic piece? Is it specific for transport?
That's a great question. That's a great question. One of the policies does, one of the areas that we would ask for a
Transport policy.
Yeah, we would be asking these agencies if they so that's a really good question.
So it should be anybody who runs on an emergency call is what this is based for. So anybody, any agency that goes on an emergency call or has interaction with pediatric patients, that's who this is targeted towards.
So not specifically only transporting agencies, it would be covering both EMS agencies that don't transport to the hospital. Including,
so air transport, Dr. Wood, is a separate deal. So this is all ground for now. There's only one other state that it actually has an air transport recognition program, and we're not there yet, but we wanted to build on this first and then add that eventually. Maybe in the second or third year, we'll look at air transport as well.
Is that because there was a difference in like our three tiers of equipment that they have different equipment according,
So it's different equipment, different personnel, different training, just all the different legalities of it as well is different. So we would have to really dig into those differences and build a whole situation around air transport.
So, a lot of what we have questions on is the leadership of this. Yeah, that's a great addition, a great suggestion, Anne. Thank you. Sure. Yeah, absolutely. Dawn, thank you. So a lot of what our questions are is about the oversight of this and how if we're going to have a recognition program, we have to verify that they're meeting these standards. And so we imagine that the steering committee would be, according to whatever bylaws we set up, which we would sort of hope to mirror our AZAAP partner and their bylaws and sort of adjust as needed. But we would imagine it would run similarly, where the members of that steering committee would be partners of ours to go out and help conduct these site visits. And I realize how daunting that is. How daunting that is to hear, knowing that we have 200 plus EMS agencies. Now we're not, ideally we would have all of them on board, but we have to start somewhere. And so I don't remember the goal we set, Jordana, maybe you can refresh me if you have that handy. I forget how many agencies. I thought it was, we wanted to say 10%. We were hoping to get 20 agencies on board in the first year.
Yeah, that was our goal for the EMS week when we present this. I would like to have about 20. I think it's a big goal, but I think we can do it if we have the buy-in for it.
Yeah. Teresa, really quickly, we haven't really discussed, other than the costs associated with perhaps purchasing the equipment that they need to become recognized, we haven't talked about any membership costs. That's still entirely undiscussed as of yet.
The reason I ask is because when we were working with the EMSC on pediatric prepared hospitals, there was, it was like $1,200 or $1,500. I can't remember the actual cost, but we ran that through the HPP grant, and this might be something that we can partner with the coalition on if there is. So just something to keep in mind that we can explore grant opportunities. I'm not, I can't say for certain that is there, but I was just wondering if that had been discussed yet.
Not specifically, Teresa, not yet.
The fees haven't been discussed. We do have some budget considerations in the long form on page 10. So that was basically like their equipment supply costs, their certification, so like their CEs and stuff like that the agencies have to go through. And then the annual community outreach projects and any materials that they would have to do for that. That was our only budget considerations at the moment. We hadn't discussed the fees yet.
Anna, see, you've had your hand up for a moment.
Yeah, I just wanted to throw into this conversation that at the very beginning of PPEC starting, I believe it was the steering committee members that did those initial site visits, right? They were our only volunteers, was the steering committee. We had to quickly start picking up other volunteers, right? So as soon as the steering committee did the first site visit at the first hospital, they had to start recruiting volunteers because there's only so much time that you can expect those steering committee members to do. And as the program starts rolling, and we have in our requirements that we haven't really enforced to the fullest that we could have, it says as part of being certified that you will participate in a site visit for another hospital. So really trying to build up that base of volunteers that could do the site visits other than the steering committee members, or you're going to burn out those steering
That's
committee
interesting.
members.
That's something that we needed, and that's exactly why we're trying to facilitate this discussion. Is we just can't see, even if we have, even if we expanded out our steering committee to 20 members, it would still be it's too many agencies to cover. And so that's okay. That's an excellent idea. Thank you for that.
And there's also the cost. So we've been doing for the last couple of years, obviously been doing all of ours virtually, but prior to the pandemic, there are, there's some hospitals that we go to that are far away in the state. So we would have to cover mileage and hotel rooms and meals for the site visit volunteers, or else it was, again, just too much to ask.
Yeah. Okay. And that's something we haven't looked at.
Gotta work into the budget. Yeah.
So I'm sorry. So, Anne, are you saying that you're asking, like, so if EMS agency A passes, then we ask them as one of the requirements to have them go to the site visit for agency B?
Yeah. Or so I think and I'll refer to Jansen on this. I think ours says they're required to participate in at least one in the next year.
Okay.
I think is what we've done. And I think that's how ours is worded. Jansen, does that sound right?
I'll have to double check on the wording, but I think it's, yeah.
I will look into it. Thank you.
Right, because it's really focused on that peer evaluation piece, right? Like we're all working together. It's not a punitive program. We are, this person, assumingly that volunteer that was at the last hospital learned something from the site visit, and they're going to carry on what they learned to the next site visit.
No, I like that. That's great. Thank you.
Yeah, that's a question we had. So that's the only. I mean, that's fantastic. Thank you.
Yeah, and without working into to have a cost for the agencies, I don't know how it's sustainable, right? Like, because eventually the grant funding that ADHS is getting is going to end. And so I don't know how you sustain the program without having a cost for the agencies.
Yeah. Yeah. Yeah, that's a very good point. We'll have to look at our grant award did increase a little bit. And we would have to just for the following year when we actually look at implementing this, we would have to look at if there's any funds we can set aside. And I imagine I can find a little bit, but we would have to sort of play that by ear and see what the costs actually would be and
Yes.
how much I could set aside to supplement site visits and those types of things.
And that goes back to what Dr. Woolridge said earlier. So, all of the hospitals were participating before we had the Medicaid bump, right? So then the Medicaid bump happened, and then some wanted to drop out after the Medicaid bump ended. So it kind of, it worked in reverse, right? They were participating and paying before and saw the value in it before, but once then there was an option to get extra money and that went away, then they just wanted to not renew. So I would just say, really think that through. Like, if you're going to offer to pay it at the beginning, are they going to want to drop out when you say the funding has ended? Now you need to pay as your own agency.
Dr. Woolridge.
Yeah, and guys, I'm not trying to be negative, Nellie. I just, I think Ann's comments and mine are to make sure that you're fully aware of the burdens going forward. I asked on the chat board how many EMS agencies in Arizona, and there's just over twice as many EMS agencies than there are hospitals. So, and Ann can allude to the administrative burden of coordinating a volunteer review process. Each review requires obtaining the volunteers, then the 4 hours during the review, which is reviewing documents and protocols and policies. So it's a pretty heavy burden coordinating and getting the volunteers for the next site visit. If you're looking at 20 as far as an initial rollout in the first year, and that's 10% of the existing EMS agencies. So the incentive, I think, is, again, trying to get the stakeholders involved, particularly the EMS directors, the medical directors. And then I think I made a comment in the chat also about the regional councils. If the regional councils can get behind it, then it's working within those regional meetings to try to identify local volunteers, and maybe even each region being your go-to person for your rollout.
Yeah, we have during the last contract amendment for appropriations for each region. Within that, each region was tasked with identifying a regional PEC, somebody that we would pipe our stuff down to, and then further on down. And that is definitely somebody that we thought would be useful in the exercise of this. Debbie, I see you have your hand up.
Yeah. I guess, I mean, I have a little bit of caution here as well, because there is going to be a cost involved here, and I've been spending some time with at least the ambulance folks, because there's the ongoing the open ambulance rulemaking right now, and they have huge concerns over sort of their reimbursement, whether no matter what position you want to take on that. I mean, they do state that is a concern of theirs, and so the benefit for this is really patient care. I don't know that there's any sort of monetary sort of benefit here. Obviously, I mean, that the experience of the hospitals with the Medicaid reimbursement, stuff shifted. I think sometimes there is a shelf life with some of these programs, unless there is a champion sort of, within the agency or within the industry that really can push the importance of this. And there are so many of these agencies out there. I don't, it's a very daunting task.
Yeah. Yeah, and I'm simply reacting to grant deliverables, and you know, I mean, it is within the confines of the execution of the grant, and if I can't get it stood up in the first year, it's not like the money stops coming in. But I suppose I have to say that we have to give it our best effort. However, that's not to say we should charge blindly into this. Like you're saying, we should have quite a bit of caution, and we should have a good approach at it, especially when everybody is doing double duty right now post COVID. Everybody is financially a little bit tighter than they have been, and so and that's the expertise we're looking for about the best ways to sort of keep those in mind and move the program forward.
Yeah, and so maybe through the EMS councils, through those regional councils, I know Rachel talked about doing some listening sessions for the rules in the councils coming up. I mean, maybe that's an opportunity for the department to, if you haven't introduced this concept, you know, at that regional level, maybe those upcoming meetings are an opportunity to do that, to sort of start cultivating potential champions. And so maybe it is a couple of it starts off as a couple of pilot programs. As Dr. Woolridge said, you know, maybe one rural, one urban.
Mm-hmm. Yeah, and those I feel like because this program is brand new, I feel like they're going to be the most integral partners in this, in understanding where the rubber meets the road in terms of finance and what this is going to cost. Because I don't see what it's going to cost when I look at the pediatric equipment list. Most ambulances ought to be equipped with that stuff, but not all are required to be. And so part of me thinks the cost will be relatively low with respect to becoming recognized according to these sort of equipment standards and personnel standards. But I don't know what I don't know, Debbie. Go ahead. Sorry.
No, I just had another idea and has nothing to, I mean, but it does start to brush up against sort of the licensure issue. It's not a condition of licensure, but obviously, I mean, you know, at least with the ambulance, you know, those agencies, they're under CON, and under the rules that are being drafted right now, there are new rules around how to evaluate those CON applications and those renewals. I mean, maybe, you know, having this type of certification is something that gives you a leg up, gives an agency a leg up in this CON evaluation. It's not a requirement, but perhaps it's a leg up.
That's interesting. Thank you for that. Okay.
You didn't hear it from me.
Well, I
don't controversial, but it is something as the department's evaluating the applications. If someone's got this, you know, I think that is it's a sign of their commitment to quality.
Right. Absolutely agree with you. That's okay. Thank you for that.
And I just added to the chat, I think it's really important to develop clear benefits to the agencies other than improved patient care, right? Because especially if you're going to assign a cost to it, right, we need to be able to show here's why it's worth your money other than just improve patient care. And for us, we offer that that they can send their nurses through the CN, CPN, and EMPC trainings for free. And that was a cost that hospitals already had in their budget. And it actually saves them money. It's cheaper for them to go through PPAC certification and get those trainings for free. And when we survey the hospitals about the most valuable benefit, that's always the number one thing, right? They're looking at what is my cost to participate in this versus my return on investment.
Okay. Okay. Yeah. And we hadn't talked about that at all. Yeah, that's something we just haven't come across yet, but yeah. We should sit down and outline and you know, the initial things we thought of was you know, being able to identify that they're an agency, so maybe some sort of a sticker and mirror what celebrate them on during EMS week and whenever appropriate, but I feel like it needs to be a little bit more than that. So
I think so too.
Yeah, thank you for that.
I think you would get some agencies that would do it just based on it's the right thing to do.
Sure.
But some are going to need more motivation.
Yeah, no, I agree with you. Okay. Boy, thank you. I'm just feverishly taking notes. Dr. Woolridge.
I just want to comment that I think that this is a great opportunity, and it has a wonderful, the motive is there, the improvement of pediatric care is there. So any of my negative questions or comments, or please don't take it wrong. I think this is an opportunity that should definitely be pursued. I think it's just kind of making sure we know the struggles that are ahead of us.
Yeah, same for me. We just want to share what we've learned over the years.
No, we appreciate it. That's why we came to you guys. And this is our first, asking is, hey, what are we doing? What are we missing? And at least on my side, that's what we're looking for, is the feedback to see what we need to do to improve this and make this as seamless as possible.
Yeah, like Jordana said, we're really asking about the programmatic gaps you all see in this, and so that's that's what we're coming to you with, and it, I very much hope you're all interested in continuing, but moving these ideas forward, and Julia, maybe you can help shore me up on this a little bit, since it is coming out of ADHS, and it will need to be approved through council. How is this driven? What does the official oversight look like? What are we modeling our bylaws after, and who are the voting members? You know what I'm asking? Should this be the PACES members proper, or should this be a parallel organization?
For PPECs, we have the steering committee who really does the bulk of the work, right? They look at it, they make sure they set the criteria, they make sure that the hospitals are meeting it, they look at the reports from the hospitals. It then does go to the AZAP board of directors for final approval. But basically it's the PPEC steering committee says, we recommend this hospital for certification or recertification. And then our board of directors has to sign off on that. And again, I wasn't here when that decision was made, but I think for me, that's an important step if it's going to be in another agency, because even though our steering committee makes all of the decisions, in the end, if there ever was a liability issue, AZAP would be the one that's responsible for that. So there's that extra step of having our board of directors give the final approval after the steering committee makes their recommendation. So that may be something that you consider, that the PACES council gives the final, okay, after the steering committee makes a recommendation. That's something you just may want to think about, like who ultimately, if it's housed in ADHS, then ADHS has the ultimate liability. If it's housed somewhere else, that agency does. But I definitely recommend that the steering committee be the one that is really doing the heavy lifting, right? They're on the steering committee because they're the experts. And so they're the ones that saying this agency should be certified or not.
I think the steering committee, if it's separate from PACES, I think the steering committee might report to PACES, and then PACES as a standing committee of EMS Council. EMS Council would have the final say, just because anything like this that is a pretty significant effort would need to be okayed by that group.
So
I don't know. Sorry,
so the pathway would be our own body, our own EMS recognition program steering committee moves it over to PACES, and then PACES sends it to EMS Council.
EMS Council, yeah. I think unless we want the steering committee to be separate from PACES, and
that's what I'm trying to hash out is exactly how the oversight of this is going to work.
I'm not 100% sure, because I can't think of another example where something like this, or I've seen something like this in the Bureau, in terms of a steering committee like this. So I'd have to think about that.
Okay.
I think you're right in terms of like regular oversight. EMS Council probably wouldn't be the right one, but for initial getting this program off the ground, and any bigger decisions that would change what the requirements are or things like that, then it would go through EMS Council. And we can definitely confirm all of this. This is my understanding. You can confirm with Dr. Bradley just to make sure that that's what she would want. But based on some of the other recognition programs, any big change would need to go through EMS Council.
Okay.
And the initial standing up of the program.
Okay. And then I think just for loop closure and clarification, the day-to-day, I guess, operations, applications, review, that would be me. I would be the FDE person that departments, EMS agencies are submitting to. I would be going back and forth with them on regular correspondence. And so we wouldn't be visiting this topic once every 3 months during the case. It would be the collection of things that has happened since the last council meeting that I've been working on, and then bringing it to the council. So there would be a day-to-day hands-on of this program. Okay.
And I guess the question is that sustainable, right, for you, Adam? Right, the first year when you're first bringing on agencies, you may be able to handle that day-to-day portion of it, but as more agencies certify and then eventually recertify, is that reasonable workload for you to kind of be that?
Question.
It's a lot.
Question.
Like I said, we
Yeah.
have a full-time manager, we have a part-time assistant. We have a lot of staff time that is dedicated just to this program.
Okay. Yeah, that's a good point, Ann, because this is one of 9 deliverables, and that sounds crazy, right? Just
Yeah.
like one thing. And so that's why we're having this meeting, is because I just don't see the full picture. I don't see how I myself am going to do this, even if I am 100% on this and working. It's just not possible. And so we're coming to you all asking, what's your expertise, what's your experience with your programs, to say how can we manage this thing and more, get it off the ground and expand it and manage it. And so this meeting has been incredibly fruitful for a lot of things that we haven't covered, because one of the things me and Jordana, that was our overarching question, was what are the programmatic gaps? What do we not see? Because I'm definitely not an expert in organizational stand-up and management, even though
I think the way that you're approaching it and getting all this information is definitely the right way. And we will definitely think more about things that we can share. I'm thinking back within the first, so when the PPAC program started, there was always a full-time manager. And then within the first several years, we had to add the half-time program assistant, because it just, once it gets rolling, then it's it's a lot of work. And like I said, I don't know if that's reasonable for your workload. Yeah.
So segueing off of that, for moving forward, should we be looking for members, or so going back to this slide of our proposed, where was that? What was that, Jordana? Is that for our committee? So because even the size of this work group is probably not sufficient for everything we need to consider, and all hands on deck. Looking forward to the next meeting, should we be looking for people to bring in that are adjacent to these EMS pre-hospital positions for input as of yet, or what does the next meeting look like, I guess, is what I'm asking. So, I mean, we have a lot to come back to and go back into the long form and look at based on what you all have said. But again, with the overarching question of the steering of this thing, of the members that are going to be participating in this. Debbie, do you have an idea or a comment?
Well, I guess a question. So in terms of the next steps, I know you had your slide on the timeline, and I can't remember.
Sorry, here, I'll go back to
remember everything, but so I guess the outlining the program, do you have, I mean, what those elements of that recognition are going to look like, the equipment that each band needs to have? Is that all like laid out already?
Oh yeah, I did. Sorry, I added it to the calendar invite as an attachment, but there was access issues, so I just emailed it to you, and let me know if you can't get to that either. But it's a 57-page that says this is the equipment for this level. It's very specific.
Okay. So that's what I wanted, the clarification. The steering committee is not going to help come up with that. That's already been developed. Right. Steering committee is really more how to sort of help push the program out, and then and to recruit and to monitor.
Yes, thank you for saying that. It's yeah, beneficial to hear for. Yeah, thank you for that. It's exactly correct.
So I would suggest before the next meeting that you have at least what you're recommending for each element of that, right? So you are recommending that the agencies pay a fee, and then as you bring in these other people from the steering committee to allow them to weigh in on it. But I would have a clear, here's basically what we're suggesting and here's what it would look like. Because I don't think you want to make all those decisions without the potential steering committee. Because I think
Right.
for PPEC, the steering committee, they were the ones that made all of those decisions together. So you could kind of go middle of the road there, right? Like make what you think are the recommendations, let them weigh in before you finalize those. Because then I think you'll have more buy-in with them promoting and recruiting and participating.
Okay. So is
Oh, that's a good question. Can ADHS
that is a good question.
even charge a fee? And that these might be, and Dr. Woolridge might know, these might be the reasons that ADHS decided to house it with AZAP in the first place.
Perhaps.
Yeah.
And I that's a bit over my head, and maybe Julie can comment on that, but I don't know if we can collect. Yeah. Okay. So we're not certain.
Yeah, I think that, to be honest with you, I think that's why Foresight, and I guess Tommy St. Mars may have to make comment on that or reach out to her to try to remember the history to it. But I think that's probably why it did evolve to that private governing body.
Okay.
But,
Interesting.
but yeah, sorry. I'm sorry, Debbie.
No, you're fine. Thank you, Dr. Woolridge. Debbie?
No, I think that's true. I don't know that you guys would have the authority, the department would, to collect a fee. So it makes sense to sort of, at some point, if it needs to be self-sustaining monetarily, that it does go to a private entity. But one thing you guys may want to do in the near future is also reach out to Access, because while, that differential adjustment program, that rate increase is, I don't believe there's anyone for ambulances at this point, but the Access, I believe, did originally help sponsor and fund the treat and refer program, which was really more for those with behavioral health conditions. But because the pediatric population is such an important population to the Medicaid agency, they may have something that they can tap into to help with some startup costs. I don't know, but it's worth a conversation with them.
Yeah, very good. Okay. I hadn't thought about that at all. Thank you for that. Yeah, reach out to Access, absolutely. Dawn, I see you have your hand up.
Yeah, this may be a silly question just because I'm not as familiar with the EMS landscape, but I'm listening to everything that you all are kind of talking through. Is there like a professional organization for the EMS agencies, like how AZAAP is kind of the professional like organization for pediatric clinicians hospitals that could be somebody to either be that third party or private entity to kind of help, but also do they offer additional like resources and certifications for the EMS? Like I know like AZAAP has options for trainings and, MOC credits and different things like that, where there could be those incentives for that overall like professional organization to help entice agencies. Because I think the thing I'm struggling with is why are they going to want to take on added cost and work when everything is so strained? But there's a need. And I think the need, like I just read a recent JAMA article from Pediatric Disaster Coalition around, there's less pediatric beds, rural hospitals are closing, more EMS are having to do kind of care in the field and treat pediatrics. We see that in some of our rural areas. And so is there a way to use the gaps and the needs out there and the shortages to help promote why this would be beneficial to them as an agency, but then leverage partnerships with like a professional organization or other professional organizations that could help with some of that like financial support? So I don't know if that makes sense, because again, I'm not familiar with the EMS like landscape, but just
You're asking, it's a totally pertinent question. And you're asking what we're wondering is, well, what I've discovered that we need to start thinking about is there a third party that we can partner with that will help us facilitate that? And with respect to EMS agencies, there's quite a few professional EMS organizations there, but they're sort of fractured up into what their function is within the service. The ambulance association, the fire chiefs association, the fire districts association. And so, I'm sure there's more and maybe more appropriate, but I don't have an immediate answer, but it's a good question. Somebody had their hand up. I missed it though, or maybe not.
I was just adding to the comments that I definitely think you're going to need to extend your timeline, because there's so many, you need to make all these decisions, finalize things, make adjustments. There's time that you're going to have to spend creating all the administrative forms, right? So you're going to have to decide, once you decide what the criteria is, you're going to have to decide what do the agencies have to fill out and provide to you ahead of time to apply for certification. What do their application materials look like? What information do you need to gather from those materials?
Mm-hmm.
Some of that has already been done in the long form, not all of it, but there's been a good portion that has been started with that, with creating forms and checklists of what is required of them.
Okay.
For the next meeting, I know we're over time. For the next meeting, should we be looking for people that are parallel with the steering committee? I guess we'll call it for the moment. Should we be looking for some of these people for input, but not necessarily begin to use the moniker steering committee? Do you guys know what I'm asking? Because I
Yes.
don't want to. This is a tremendous amount of work. There's 11 people here, and so I guess what I'm asking is, should we is now the time to start bringing in extra bodies or I guess I don't know exactly how to phrase my question, but
No, I know what you're saying. I do think though you should be a little bit more prepared with your final, like, here's what we're thinking. We will charge, we won't charge. We will, it will be housed here, it won't be housed here. Like, make some of like a clear picture of what you're proposing before you invite them in to provide feedback.
okay.
Just so you're not having these exact same
Yeah.
conversations with them.
Okay. Don, I
I
see your
also-
thing there.
I also think it'd be helpful to have kind of a detailed, essentially toolkit available. This is a product that's going to help your agency care for kids. And that product can be anything from, guidelines, protocols, stocking lists, because you're bringing something to the table that you're giving to that agency that is going to result in improvement. And I think along with that is, welcome aboard to our essentially designation program. But the
Mhm.
more complete, like I think that was Ann who was speaking, the more complete your packet is and more detailed, I think the less apprehension.
Yeah.
I mean, again, we're looking at agencies who may very well have all the best of intent, but I put in the chat, there's going to be a cost to the agency, whether it be the additional stocking they have to do, and ultimately it's the low volume of pediatric transport that we're focused on,
Mhm.
because adult transport, pediatric transport pales in comparison to the adult volume.
Mhm.
I think there's also, you're going to have to spend time on your internal processes. What is our internal policy if, right? Like, so what if we go to a site visit and even though they said in their application that they were going to meet all the requirements, they didn't? What is our internal process for how we're going to handle that situation? What is our internal process for, like we said, who's approving it and the turnaround time that we have to report back to the agency if they've been approved or not? I think there's a lot of what if internal processes that if you wait until you try to do the first couple site visits, I think then that will be very overwhelming at that point.
Right. So moving forward, can I say that it would be safe to just continue soliciting PACES members to help us answer all these questions, to formulate this more into more of a product before we move forward, and it would rest with us for the time being? Is that safe to say?
That would be my recommendation.
I mean, because I don't want to just plop this on PACES as because you're a PACES member now that you're automatically a part of this. But I guess what I was asking was, you know, who is the experts that we're asking up until we're looking for these steering committee seats for their input. But thanks for your input thus far about needing to formulate it a little bit more. As a quick note, the timeline was set by the grant that in the first year the first year was the prep for all of this.
Yeah.
And then by the second year they wanted EMS agencies, and without thinking about it, it was like, you know, okay, that's sure. Yeah, sure. Yeah.
The whole year. Yeah.
But now having this first conversation, that seems wildly hopeful. So, I mean, we'll do the best we can, but okay. So I guess what I was looking for was who can I rely on to bounce this stuff off of? And it's going to be you guys until we're able or ready to start looking at steering committee seats, if you will.
Yeah.
Okay. Dr. Woolridge?
Yeah, and just if you wouldn't mind, Adam, clarify what are the teeth behind this? Now, this is a component of the state partnership grant. And HRSA is going to want you to report at the next stakeholder meeting or the grantee meeting.
We have performance report periods where we essentially just do that. We fill them in on what progress we've made thus far. And you know, like I said, it's going to be okay if we don't have the program stood up in a year. I'll have to check the box that no, we haven't stood it up yet, but I will be able to say we've hosted all these meetings. There's a bunch of product. And so it's not a binary outcome with my grant as a deliverable. I think that HRSA is going to look at this and say progress is being made. That's okay.
Yeah.
Okay. It might be helpful that at our next working meeting that we have some sort of a template of what the toolkit's going to be. And I understand there's a series of other states you guys have already looked at.
Mm-hmm.
Maybe if that information was disseminated or if you compiled
Sure.
what you think could work in Arizona.
In between this meeting and the next, I would encourage you all to, and I hope you got the email, let me know if you can't access that document. But it's 57 pages in and of itself. But in addition to that, there's several hyperlinks in there that take you to all of the places we used to derive this document. And so it's a tremendous amount of information to go. Okay, thanks, Chief Crowe.
And then I got the email from you, Adam, but it only has the agenda in it and not the other document.
Okay.
I think there's one that just popped up that has the larger.
I sent it during this meeting, so if you haven't checked your email,
yeah,
sorry, but let me know that there.
So some of the states that I went off of was Texas, Missouri, North Carolina. So I did look at many different ones. Some of them that I did look at have a very lax program, I guess I would say, where they weren't very stringent on having all this criteria that we would like to see in our state to have. So I did look at some of the ones that had a little bit more meat to their program and took from them mostly, because I did like to have a little bit more pride in our state and have those expectations of our state.
And I'm sure there's a balance between you know, asking so much and being, you know, making it so easy that you know there is no real improvement to that. And so yeah, that has to be struck. That balance has to be struck as well. Okay. Well, we have some work to do. We're the next meeting. We'll go back and do see how many of these recommendations we can implement and smooth out for next time. And I'll do the same thing I did this time, which is just facilitate, not facilitate, but solicit for PACES volunteers to help. And because these are public meetings, I'll follow up with minutes and agendas moving forward.
And I just want to say thank you to everybody to help us. And I don't think your comments were negative. I think that's what we need to hear. And that's what we're looking for, is to make sure that we are doing this effectively and correctly. So thank you.
Yeah.
Thank
Okay.
you.
Okay, everybody, I'll follow up with minutes. Thank you so much. We appreciate your time. I know we're running over, so thank you, thank you, thank you.
Thanks, Adam. Talk to you soon.
Thank you. Appreciate your input.
Thanks, Adam.
Yeah.
Thanks, Adam. Take care. Bye.
Thank you. Take care. How'd that go?
I feel like we weren't very prepared.
Yeah. It's
I felt
It's-
like we were good, like we had a good grasp on it, but then talking to them, I feel like we really didn't have everything that we needed to have ready for them.
No, and that was like that. That was that caution that I couldn't put my finger on. That I was like, I feel like we're ready, but I don't know. And so,
But I think we needed this, because you and I have never done this before, so we need that input of these people that have done this,
Yeah.
and have those other backgrounds that.
Oh shit. There you are.
I don't know what happened.
On-
So, no, I was just saying, I think that they had some good points. We had a good rough, but we needed the internal stuff that we just didn't know how to do. And I think we
Yeah.
need to figure that out. And I don't know how to figure that out.
Yeah. I mean, we got a few pieces of work to do, but it's what they gave us was pretty somewhat abstract. Like the benefits to agencies, that was clear. It's like, we definitely need something that is like, if you're part of this program, this is the shit you get with it. That's very clear. But like reaching out to Access, a third-party agency, like I have no idea of somebody. Who the hell can I hand this off to that can just do it? Because that sounds great. That would be the first thing I do, So
Right.
And that's why I was really trying to like, can you help us derive a steering committee for this thing? And so, but that's kind of why I clarified, like, so it's going to be you guys. It's your guys gonna be one helping us with this. I don't know. I don't know what I need to know. And so, anyway, all right. Well,
like the Medicaid thing, like I get that. That's a great, because they have to bill. You have to bill for transport. You have to bill for emergency services. So
see, that went over my head. I don't even know what they're talking about with a Medicaid bump. What does that mean?
Okay. So with so you have Medicare and you have Medicaid, and you have to be we have to have like steps and certifications in order to be able to treat patients.
Uh-huh.
And those are certifications. So you have a Medicaid certification, you have Medicare certification. They have basically laws you have to make sure you do, like things you have to do. And if you don't do that, then then you lose the funding. So if I'm a medical provider, I bill at X amount of dollars and have insurance is already going to reimburse for X amount of dollars for said procedure for their for the ICD-9 code. And so if your ICD-9 code has attachment of what Medicaid will pay and what Medicare will pay, what Blue Cross Blue Shield will pay, whatever will pay. If you don't have those backings, then you as a provider don't get reimbursed.
Okay.
For whatever code that you coded your care for.
Okay. All right.
Does that make sense?
Yeah, I need to look into it a little bit more, but I see what you're saying. Okay, all right. Well, let's circle back around to this. I'll give us another ad hoc meeting this week. Is there a day that's better for you? Does it matter?
Let's just see. I don't think I have. I think I'm good.
Okay. I'll just message you one of the mornings and be like, hey, let's set up a time today, and that's what we'll kind of tackle this from there. But we've been in a meeting for an hour and 15, so let's call it for today.
Okay.
All right. Thank you. Appreciate you. Nice work.
Thanks. Bye.
All right. Bye-bye.